Assalamu alaikum warahmatullahi wabarakatuh. Hello Jonah Club listeners. This is a case series published in the International Odontic Journal 2025 by a Brazilian group to evaluate the intentional mechanical negotiation and filling of accessory canals with CBCT-based volumetric healing assessment. All cases were treated by a single endodontist, planned and followed using CBCT, evaluated with a mean follow-up of 10 months. The rationale is that the accessory canal are often considered minor anatomical variation that harbors residual infected tissue and contribute to the main cause of the endodontic failure, which is the persistent periapical infection within the root canal system. While passive sealer extrusion into the accessory canal sometimes occurs, the intentional mechanical negotiation is rarely documented due to their small diameter, the severe curvature, and the limited detectability on periapical radiographs. And there is no currently a strong clinical evidence that clarify whether to actively instrument these accessory canals and if this would improve their healing outcome. Therefore, this study aimed to demonstrate the feasibility of intentional accessory canal negotiation, to describe a reproducible clinical protocol, and to quantify the periradicular healing using 3D CBCT volumetric analysis. For the methodology, 6 teeth were included with the accessory canals clearly identified on the CBCT. All of them were associated with bone resorption at the baseline, also with the CBCT suggesting their possible pathogenic role, and they performed 3D segmentation with the volumetric bone loss calculation, and the healing was measured as percentage volume reduction. They confirmed the accessory canal preoperatively through the CBCT and the 3D segmentation, clinically by the tactile sensation of the pre-curved size 10K file, and confirmed it electronically with the use of apex locator, and radiographically with the periapical radiograph with the file positioned inside the accessory canal from 2 different angulations. Also confirmed post-operatively with the post-obturation periapical radiograph with the sealer extrusion into the accessory canal, and at the follow-up CBCT showing that the filling material within the accessory canal. For the proposed clinical protocol was first that the case has to show clearly visible accessory canal on the CBCT and associated with periapical bone resorption. Second, the CBCT planning to take measures first at the emergence point, the angulation, the distance from the anatomical landmarks, for example, the cusp tip. They standardized the clinical preparation to first start with the main canal to prepare it with a rotary instrument to size 40/05, and then irrigate using 2% chlorhexidine gel with 17% EDTA and a passive ultrasonic activation for 3 cycles, 20 seconds each, and then negotiating the accessory canal using pre-curved size 10K file, perform watch winding and balanced forced motion, and confirm its patency using apex locator, and enlarge it up to size 20. If there was a curvature that's more than 120 degrees, only patency and light debridement was performed using small size 10 and 15K files. For the obturation, they were all obturated using gutta percha with AH plus sealer in warm vertical compaction technique, and then followed up and performed the CBCT segmentation and did the volumetric bone resorption reduction calculation. For the results, all the accessory canal were successfully negotiated and filled with the sealer. All patients were asymptomatic at the follow-up. All the accessory canals were associated with a baseline bone resorption. There was a reduction ranging between 33% to 100%, with 2 cases showed complete healing. For the limitations of this study, other than its small sample size and its design itself, which is case series, that does not allow us to make any causality conclusions, there is no control group, which makes it impossible to know whether the observed healing was specifically due to the instrumentation of the accessory canals manually or because of the conventional root canal treatment itself. And it has a short follow-up period of a mean of 10 months. And in addition, I think the standardization of the main canal preparation up to size 4005, which in their paper explained that this adequate enlargement would allow an improved irrigation, disinfection. This may not be clinically applicable in all type of teeth in different anatomical situations, because narrow or thin canals may not safely tolerate this level of enlargement, specifically in cases like mandibular incisors, the mesobuccal canals of the maxillary molars and lower molars, which limits the clinical practicality and the reproducibility of the proposed protocol. Finally, in my opinion, I think that although the study does not prove that the accessory canal instrumentation could improve the outcome, but it provides the most detailed clinical roadmap so far, with integrating the CBCT imaging and the technology in the 3D segmentation with the complex anatomical management. Some to take home messages are that the intentional negotiation of the accessory canals is technically possible with the CBCT planning and the use of the microscope, and that the mechanical penetration may enhance the chemical disinfection effectiveness, and finally that the CBCT volumetric analysis can provide a quantifiable and objective healing assessment. Thank you so much for listening. Hope you have a good day. Bye.